Okay, so good morning and thank you everybody for spending the time, especially across multiple time zones. It's certainly a new world that we live in, giving talks like this, and I don't know that I'm all that good speaking in general, but certainly not good in this format. So if there are questions, please feel free to interrupt and ping before we go on. I'll be speaking a little bit about some of our experience in computer modeling for complex conditions, mainly in kids, but obviously can be used in adults as well. There we go. So some of the benefits, and we've been using this technology for a long time, right? Ever since CT scans were able to do 3D renderings, we've been able to spin and be sort of oohed and awed by having these three-dimensional reconstructed views. But I think it's over the course of the last probably 4 or 5 years, maybe 6 years, it's really been taken to the next level. Primarily, we have 3 main benefits from using 3D modeling. One is to visualize fractures, deformities very, very well. Both for our own individual preoperative planning purposes, but also for patient education. And then, of course, I think that the real significant seismic shift has been in intraoperative execution. And I'll go over some examples of each of these. So visualization itself is actually very powerful. I think most of us as surgeons are very visual creatures, and we have sort of this innate ability to do pattern recognition. But sometimes it's very difficult to see subtle deformities. Here's an example of one, and I'll show you the case a little bit later, where the deformity was so subtle that it wasn't until we had CT scans in both that we're able to see the subtle but quite significant deformity. We're not really used to looking at surface changes. We sort of three-dimensionally think about them when we look at two-dimensional images. It's also hard to take into consideration the deformities due to remote sites from the primary site of pathology and the complex relationships between bones, especially the forearm. In addition, it's almost impossible, at least in my mind, to preoperatively predict range of motion without having some sort of plastic model. And we routinely get plastic models made both for ourselves and for patients that our engineers make, but these are just 3D printed on a relatively inexpensive printer, which are invaluable in being able to hold and look and touch and see what we're going to be operating on in the future. So clearly they are perfect, and we'll go over some of the pitfalls and some things that we've learned in the process of using these tools. Here are some examples of the 3D printed models that we have for preoperative consultation with patients. In terms of planning, I think the most significant benefit is that we're able to test multiple unusual osteotomies. So unlike having a set of osteotomies where you make a simple cut perpendicular to the long axis of the bone and perpendicular to this long axis and put them together, clearly very useful, and it's something that we can do instinctively. Sometimes very unusual complex osteotomies are the best way to take care of some of these problems. We're also able to choose hardware preoperatively, and it allows us to kind of think about the fracture in ways that we weren't otherwise able to do. And most importantly, I think, or the most significant change in the past 5 years has been the use of these 3D planning processes for intraoperative execution, where we can actually do not only simulated cuts, but also simulated plates and screws, so that when everything is completed, we have a set of 3D printed cutting guides and drill guides that allow us to, I think, more precisely take care of some of these complicated issues. So the current state for these complicated deformities, not saying this is wrong, and we certainly use this on a regular basis as well, is we take the fraction of the deformity, and we make a cut in the bone at the apex of where we think that the maximum deformity had occurred, open the elbow joint, put the radial head back in, and then plate. And it's fine. And for many cases, it works very, very well. But sometimes the intraoperative futziness can be avoided with some preoperative planning. So is there a better way? Of course there is, otherwise we wouldn't be chatting about this. There are quite a few companies out that help surgeons perform these exact tasks. And these are 2 of them that we've worked with in the past and currently work with. There are actually quite a few more as well. And these companies are tremendous service. They are quite expensive, at least in the US they are, but they've been invaluable in helping us preoperatively plan. And I'll go over a couple of cases that will illustrate how helpful these can be intraoperatively. In general, the plan for this, for any of these processes is to get CT scans of both limbs If it's a congenital condition where both limbs are affected, then at the opposite side, or the quote unquote good side, is oftentimes an age-matched control CT scan that we have sort of lying around, or the companies have lying around. But frequently it's the opposite limb for the child for a post-traumatic deformity. We do three-dimensional reconstructions, and then the image to the right, you can see the blue image is the quote unquote normal bone, and the white image is the bone that's deformed. This is a Madeline's case. Through planning software, with the help of an engineer, we're able to sit on the computer and actually map out potential osteotomies. And this has been incredibly enlightening, both for our individual patients that are treated in this manner, but also in helping us understand where osteotomies can be placed. It gives you a tremendous amount of comfort knowing that you can actually do preoperative osteotomies in multiple locations and really maximize the improvement in the deformity for the child. Here's an example. I think this is Dan and Scott's case from their paper. Madeline's is uncommon enough, traditionally treated by a very complicated set of osteotomies. It's a dome osteotomy. Now you can argue whether a smiley face or reverse smiley face is the best, but we get good results and very consistent improvement in overall correction. But sometimes the deformities are quite significant, and a dome would be, I think, arguably a little more challenging in these cases. So just to emphasize the steps again, it's preoperative CT scans currently of both an affected side, the affected side, and an unaffected side, either control or the opposite side, in silico osteotomy planning. And I think it's important at this stage is to be creative. And this is the time where there's no operative time clock, there's no tourniquet, there's no child under anesthesia, but be creative. And we found that we've learned a tremendous amount about the pathology of some of these fracture dislocation patterns that's been useful. And I think some of these things that we'll be able to use, I think, even without the use of these osteotomy guides. Once you choose your osteotomy plates, these companies will 3D print cutting guides and drill guides to allow for proper placement of the osteotomies. And I think what the benefit is that putting drill holes in a bone that's intact, sort of like doing fracture fixation on a sawbone that hasn't been cut, is significantly easier. So it's nice to be able to drill holes in a bone that's intact. So here's an example of one of our preoperative states that we had planned with the company that we had used for this, which materialized the postoperative simulation. Here are the preoperative x-rays and the postoperative x-rays. And Manon has done a very nice study, which I'll review in a couple of seconds, but essentially we're able to get really close to the osteotomy that we had planned. So it's a fairly accurate, still futzy, but a fairly accurate way of producing these very complex deformities. Here's another example of a Madeline's case that we had, the preoperative 3D scan. Here are these unusual osteotomies that I don't think that I would have ever been able to see intraoperatively. These are examples of the drill guides and the cutting guides that have K-wire placement into the guide to allow for correct alignment for each of these guides. So everything is done quite precisely. Here's the simulated corrected view postoperatively. And here's the pre and post-op x-rays. So again, not perfect, but I think at least for me personally, significantly easier than trying to do an intraoperative osteotomy. This is work that Manon has done, and I hope this is the updated data. But we looked at the Shriners and HSS experience, where we had a total of 8 cases, 7 patients, average age of 13, where most of the Madeline's case that we had, we used double osteotomy for, which is something that we had not typically done on a regular basis before that. There was a significant improvement on the AP radial bow, not on the lateral. But overall, I think the experience has been quite comforting, knowing that we're actually performing the corrective osteotomies that we actually had planned. So the benefits are that we can do, I think, creative osteotomies in a way that we have not been able to do before, including significant rotational correction, which I think is very challenging. Multiple osteotomies leave us with a bone or an overall improvement in position, which is more natural. It looks more like an anatomic radius than we're able to do with a single osteotomy. The operative treatment itself, we're drilling on a stable platform. We're not drilling through tiny little holes. We're not making multiple fractures and trying to fix them. And we're able to pre-contour plates so that when things are complete, we are able to put this together again quite quickly. Two more quick cases, and hopefully I'm not going too over time, but here's a patient, 5-year-old, fell off a jungle gym, had a missed Monteggia with limited flexion, preoperative x-rays shown here. MRI showing that the radial head was getting a little bit of wear. Here's our preoperative planning. Blue is normal, and you can see it on here, the radiocapitellar joint is located. White is the abnormal site. So in this particular case, we use the child's opposite side as a template. We're able to do a preoperative planning osteotomies. And in this particular case, what we've learned with Monteggia is that 2 different sites of osteotomies, including one that's fairly distal in the mid shaft of the ulna, dramatically improves the ability to correct both the radiocapitellar dislocation, but also the varus valgus angle that's been abnormal due to the child's dislocation. Here's a preoperative plan. You can see here the osteotomized site is very close, relatively speaking, to the good side. Plates and screws that were designed preoperatively, including the osteotomy proximally. This system does give very subtle information, like the degree of bend that we needed, the distal osteotomy, the distraction needed, and even the screw lengths, which are fairly accurate. Certainly not anything that I would rely on, but they're fairly accurate. These are leaps of faith drill guides. If you put these on, you'll be drilling in these crazy directions, thinking, my gosh, I hope I'm not maiming this child. And cutting guides are just as crazy. But at the end, preoperative and postoperative results are actually very close to what we had planned preoperatively. This particular case, I'll just give one quick anecdote. I think Dan and I did this one together, and we forgot initially to put the 4-degree bend in the distal ulna plate. So we put this entire thing together and the radial head was still out. And then we realized that this 4-degree bend wasn't pre-contoured, took the plate off, bent it, and instantaneously this radial head went back into position. So the power of having this done preoperatively is actually, sorry, my overtime.
No, you're good. I think that was a sneeze.
Oh, so here's a comparison of the sort of traditional version. Again, for a subtle deformity, I think this is certainly fine. You can see the ulna is not a normal looking ulna. Not that it matters, but it is nice to restore anatomy. Whereas if we are able to osteotomize at 2 different sites, we both correct the varus valgus deformity, which we can't see in this x-ray, but also we get a much more normal appearance to the ulna with a second osteotomy site. And some of these single osteotomy sites, Monteggia, can be quite challenging. Last case, which is the case that I showed earlier, it's a 14-year-old with a very subtle deformity with and instability. And even with full form x-rays, the deformity is quite subtle, and it's subtle enough that it's hard to convince yourself to do an operation on a child that doesn't have a dramatic deformity. With 3D preoperative planning, we're able to see the deformity at the distal radial ulnar joint was actually quite significant. And that's quite, once it's well visualized and you sort of get this confidence that you're not going to be hurting this child. I think doing the osteotomy is quite simple, and this child had a complete resolution of symptoms with that very mild deformity. So there are pros and cons with this. I mean, there's no doubt that I think we are faster intraoperatively using these methods. We've learned a tremendous number of things that I think have helped us in doing even regular cases that we're not using this 3D planning tool. I think it's always nice to be able to front load your case, complicated cases, by thinking preoperatively, and this allows you to do it at a level that wasn't previously possible. I think we're getting better corrections. I don't know that for sure, but I think we're getting certainly more precise corrections. And really complicated multiplanar corrections, including rotational corrections, are just easier now. We're able to do a lot more things with it. There is a tremendous amount of time preoperatively on the con section. The cost is significant, and we're able at our hospital, they allow us right now to do this on a case-by-case basis, which is very nice. One thing that we are learning more and more about is the tissue compliance makes it challenging. So anything over about a centimeter and a half of an acute lengthening is actually quite challenging. And I do think that there is a time element. If the longer time between the injury date and the time of the osteotomy, soft tissues become less compliant, and some of these can be challenging. Some of these were quite difficult to get into position. The timeline, there's a little bit of a rush. The FDA in the US mandates that most kids are operated within 6 weeks of the date of the CT scan. So we actually find a surgical date and work backwards from that time period. And that's because of obvious continued growth of the child, which could negate the benefit of the 3D printed guides. And a lot of the things that I would find very helpful in my practice aren't cleared yet. So at least up until recently, and I still think currently, one of our materialized is not cleared for distal humerus osteotomies. The cost is tremendous. It's about $4,000 in addition to the plates and screws. So this is not an inexpensive thing. It's the cost of your time is quite significant. It takes about an hour and a half of your time preoperatively, and then the intraoperative time does reduce though. So thank you, and I'll take any questions that anybody has.
Thank you, Aaron. Manon, can you unmute? Yeah, perfect. Manon, you're muted. I'm sorry. Chesko, can you send her an unmute? Yeah.
Sorry, you hear me before?
No, but we hear you now.
Okay, so first, thank you really much, Dr. Zlotolow, to welcome me in this meeting. And Dr. Daluiski, thank you again for welcoming me last year to do this amazing work on PSI. As you said it perfectly, I think it seems obvious for the surgeon for the benefits of the 3D planning and customized guide. And it's true there is some limitation. I don't think cost will be a limitation because it proves that we save our time, and there is a real benefit for the patient. This point, it's also difficult to prove on how theory, because clinical improvement in severe deformity is difficult, but I'm sure with a larger use of customized guide, it will be a limitation that we will pass through. The main limitation for me is the irradiation, because we need to do a CT before, and even if you save irradiation during the procedure, the CT that you have to do before still makes the global irradiation still high. So yeah,
are there any questions? Please put your questions on the here we go. So there's a question about MRI-based 3D printing, and I think, Aaron, you're working on that, right?
Yeah, so Manon, actually, I think you're involved with that as well. I don't know if you know it or not, but Manon and I have just literally within days have gotten some funding to start playing with a sequence on MRI that is very close to CT scan surface area reproduction. So I think that we'll be able to get hopefully close enough to be able to eliminate the use of a CT scan and just use a different sequence on MR for this. But yes, I think it's a great question, and I think that's the wave of the future.
Yeah, I know it's interesting also, Olga, since you're on here. When I went to visit Olga, their CT scans were amazing in terms of their soft tissue resolution, which I've never seen anywhere else. Except, I mean, we've tried that, Aaron, if you recall, right, to do the same with great difficulty. But one thing that I've talked to Materialize about is because one of the big limiters, as you identified, is you see the bones, but you don't see the soft tissues, and the soft tissue limitations can be significant. I've talked to them about using MRI or using soft tissue windows on or settings on the CT scan to sort of have an idea of where the tendons are, where the muscles are, where vessels are. So because you may have this great idea of where to put your jigs, but when you get in real life, you can't do it. I mean, I remember specifically doing a clavicle case where I could not get the jig on because of the patient's head, right? So I had this really well-planned osteotomy. I tried to put the jig on. I'm like, oh, the head's in the way. I can't actually do it. So we had to change everything. I don't know if Scott, you remember that? Yeah. So I don't know. Yeah, Olga, do you have any suggestions on soft tissue CT scanning? I don't know how to unmute you. There you are. Thank you, Jessica.
We use this method in our practice a lot, but sometimes we use MRI CT examination because our patient have different severe deformity, soft tissues, bone, and CT examination helps to find proper treatment when we get full picture, clinical picture of all pathology in our patient. Yeah. But sometimes when patient has only soft tissue deformity, we perform MRI examination.
Yeah. And Manon, do you wanna go through the chat questions?
Yes, okay. I think like the question is for the adjustment of the different slope for lunate and scaphoid. I think like Dr. Daluiski told me if I'm wrong, but it was to restore the best anatomy as it can be done, because most of the times there were bilateral cases. So to be closer as possible of a normal anatomy.
I think that's right. And at least a couple of cases, we've been tempted to do an intra-articular osteotomy, which it's hard not to go down rabbit holes when you have this tremendous visualization preoperatively. And I think a couple of times, actually, one particular case we were doing here, and I got Dan's advice on this, and he looked at me and scratched his head and he goes, "Are you crazy? Why would you ever do that?" And you take a step back, and of course, I mean, why would you have this 5 by 6 millimeter piece of bone and try to get it well fixed? We wouldn't do it without the system. So I do think that it would be great to get an intra-articular osteotomy and restore both, but I think just getting the platform, the end of the radius, so that it's a stable base is the same way that we would do with any other osteotomy is where we stop.
There is another interesting question on the chat is about the intraoperative targeting to position the guide. It's a really interesting question because the one limitation with the customized guide, it's the accuracy of positioning the guide. And there is a difference between the two companies. For example, Materialize, you position the guide with a press fit technique. So the guide are bigger, so you need a small surgery wound, and new clip. You need to control the position of the guide by fluoroscopic. So it means irradiation, but the guide are then smaller. So it's something that we need to work on. It's the accuracy of the positioning the guide. Because after you don't have any flexibility, you have to follow the procedure. So it's true that to assess the reproducibility, it's a really important question.
Yeah, if you don't position the guide properly, and I've talked to Materialize about this on how to make this more accurate, but that's your base. If you don't have your guide placed properly, everything else will be off. And so we spend a lot of time on that particular step. But I don't know if there's any, David, do you know of any intraoperative guidance that you can use? Let me unmute you. Hold on one second.
I was just, the difficulty, particularly with the case Aaron pointed out, with the really subtle deformity with the DRUJ instability, that's going to be a very hard, the deformity is so subtle in that with rotation, angulation, that the radius or the bone is just going to look normal. and where you place your guide on that is going to be critical in terms of result, but difficult in terms of accuracy. So the major joint arthroplasty guys are using intraoperative 3D fluoroscopic targeting, robotic surgery to position their cuts and their cutting guides, but I haven't seen that in extremity surgery or in upper limb extremity surgery yet.
Certainly would make it easier.
Well, it makes it more expensive and bigger. More pins and more machines in the operating theatre, but but the results are great. But I just wonder if you got it wrong, then if you got the plate in the wrong spot, it'd be pretty difficult. Yeah,
well, think about that case that Aaron mentioned, and I remember specifically that 4-degree bend in the plate. So, I mean, the 4 degrees, just 4 degrees bend on a plate made the difference between a reduced radiocapitellar joint and a dislocated radiocapitellar joint. That was an amazing experience, because we tried this and we're kicking ourselves and we're thinking, what a disaster, right? We've done this huge osteotomy and nothing worked. And then we just go, it's like, oh yeah, we forgot the bend. And I'll tell you another sort of anecdotal case where really complex deformity on a girl with Olier's disease. And she had a radiocapitellar dislocation, ended up doing a materialized designed cuts on her. And everything looked great. And it was perfect. And the radial head would not reduce. And so I said, okay, that's too much surgery. I'm going to come back another day and I'm going to reduce the radiocapitellar joint. And I see her back in the office. I take an X-ray and she's reduced. So it's almost like it was the spring that just loaded the radiocapitellar joint until it reduced. And she's now maybe 3 years out, still reduced. It's crazy, the power of these things. And osteotomies that you would never think about. I think to Aaron's point, certainly like the idea of Monteggia correction, much more distal on the ulna. If you think about it, you can do a lot more, it's because you're changing the position of the head, right? So if you make your osteotomy far away from it, the arc, right? You don't need a big degree change to change a huge arc, right? Whereas if you do your osteotomy very close to the head, you need a tremendous change in degrees to change this, to make that same arc. So that was an interesting learning point for us. So any other questions, Manon, that you see?
No, there is no other question on the chat.
So if we're...
The police means that we have to change the subject.
I'm changing. You kind of look like the village people. Is there, right? So... Well, should we move on to Paul's talk? Is he next? I believe.